getting them.
Uploading of the slides.
Exactly. Yours is up here. I just got to kill this. Perfect. Thank you.
You're welcome.
No problem.
Good morning, everybody. Morning. If we could all get ready and have a seat. So again, welcome to Rochester. Hope everybody's having a wonderful time and a good morning so far. This is going to be our second general session, and we have a wonderful lineup prepared for everybody that's here. My name is Dr. John Eaton. I'm one of the gastroenterologists and transplant hepatologists at Mayo Clinic in Rochester, and I'll be moderating this session with three of my wonderful colleagues. So our first speaker is Dr. David Assis. Dr. Assis is a gastroenterologist and hepatologist who comes to us from New Haven, Connecticut at Yale. David is a funded researcher both within the sphere of autoimmune hepatitis and also within the sphere of PSC. He is a recipient from the PSC Partners organization for his research endeavors, and we're excited to hear what he has to tell us about PSC management and quality of life. Thank you.
Thank you very much, Dr. Eaton. I want to thank Dr. Eaton, Dr. Lazaridis, the whole team at Mayo, and of course the PSC Partners organization for the very kind invitation. It's a wonderful meeting, and I hope that everyone leaves here inspired to go back home and to keep pressing on because we are making progress together. I've been asked to speak about the management of PSC and quality of life. Certainly there's more than can be discussed during a 20-minute session, so I would also look forward to your questions during the Q&A session. These are my disclosures. So I thought we could speak a little bit about some of the pharmacologic management of PSC, or perhaps highlight the shortcomings currently of that. Endoscopic management, monitoring for cancer, bone health was very eloquently discussed for the most part in the previous session, so I won't dwell on that. And then just a little bit about symptoms, quality of life, and perhaps the role of patient-reported outcome measures, or PROMs. How about we start by just bringing everyone on board to the current status then of pharmacologic management for PSC. So currently, there is no proven pharmacotherapy for the treatment of PSC that is able to reduce disease progression or improve mortality. Now, I think Dr. Linder later today will go into detail as to the current landscape of clinical trials, but I think most of us are aware that there are multiple trials underway to fix that. But one thing which is closer to us in terms of prescriptions and patient experience is the bile acid modulation, meaning ursodeoxycholic acid. And while this is not intended to be an exhaustive discussion of that whole topic, I think that is a very common question. Many of you, or many of us, are familiar with prescribing, and I thought we should spend a minute on this because this has to do with pharmacologic management. So moderate dosing with UDCA, which is closer to 15 milligrams per kilogram per day, has been shown for several decades to be associated with improvement in liver tests and of quality of life. But it has not been shown convincingly to improve mortality. And so I tell patients who are on ursodiol or ursodeoxycholic acid that it certainly can help the numbers look better. It can help the bile flow better as a lubricant for bile in a way of understanding it. But it is not able to reduce the strictures. High-dose ursodeoxycholic acid, or UDCA, unfortunately was shown about 10 years ago in a study generated here at Mayo Clinic to have increased adverse events and negative outcomes. And this led to then some divergence in the recommendations from the different societies that guide clinicians for treating patients with PSC. The 2010 guidelines from the American Association for the Study of Liver Disease recommended against UDCA completely, whereas other European and American GI societies left some room there for moderate or lower doses of UDCA. There was an interesting prospective study of patients who were on UDCA and who then had the drug discontinued to see how that would play out, both in terms of symptoms and of labs. And in this prospective study, many of the patients actually had a deterioration in serum liver tests and in the Mayo risk score after UDCA was stopped, along with increased incidence of pruritus and reduced quality of life. I had one patient in front of me saying, goodness, you can't live with it, you can't live without it. And certainly that can be a challenge for some patients who are prone to that symptom when the medication is discontinued. And so I think the first point I would make for management of PSC is that there's some lack of clarity, you could say, certainly from a patient perspective in terms of what we recommend and at different time points. I hesitate always to make any blanket statements. I'm sure you could agree. Every case is unique and different. But I, in my personal practice, am currently not initiating UDCA for new patients with PSC, with a few exceptions, unless the patient has elevated liver tests and symptoms, and also is not eligible or interested in clinical trials. In other words, I do feel that we need to promote and identify newer and better medications that might be effective in this condition, and I would probably rather spare that medication and move to a more promising therapy than starting it, with a few exceptions, like I said. How about pharmacologic management in the sense of the microbiome? This is something that is becoming increasingly a question that I get in clinic because the microbiome is all the rage. Clearly, there's a lot of promise in how we view this, and this is a topic that is going to be discussed throughout the day, I believe. Oral vancomycin specifically has come up as a question, and I'm not saying or putting this up here to say that we have all of the answers or that it's even recommended, but it is a practical topic that is coming up more recently. There was one study also here from Mayo Clinic suggesting a reduction in the serum alkaline phosphatase in small studies, and it might be also associated with some improvement of colitis. But as Dr. Goris said, we really don't have enough knowledge of how to manipulate the microbiome to make this a routine part of our pharmacologic management for PSC. And very fortunately, and I believe Dr. Linder will probably mention this, that there is a randomized placebo-controlled trial that is pending, and I think we all look forward to that. Probably more practically speaking, though, for medications that are prescribed for patients who have PSC, not because of the PSC, but because of ulcerative colitis, vedolizumab is increasingly a question that comes up in discussion with patients who have inflammatory bowel disease and also have PSC. So vedolizumab, trade name Entyvio, is a humanized monoclonal antibody that can help to prevent the immune cells, the lymphocytes, from causing inflammation in the colon. And it is approved for the use in Crohn's disease and ulcerative colitis. Will this benefit patients with PSC? I'm only putting this up here because it's a very practical question that comes up week after week, and whether this should be part of our management strategy. The largest collection of patients studied to date was an international retrospective study from the International PSC Study Group. And you can see there in the spread of the graph that the patient experience in terms of reduction of the blood test alkaline phosphatase was really highly variable. Some patients had a mild increase in alkaline phosphatase, others had no change, whereas others yet had a reduction. So it seems truly to be all over the place. More importantly, perhaps, for safety concerns is that there was not a detection of a safety concern from patients who have PSC who are receiving vedolizumab for treatment of their colitis. And I think as time goes on, there may be even some subsets of patients who have PSC who might benefit from this medication, but we are far away from being able to recommend that as part of our routine management. But I tell patients at this point who are considering vedolizumab for treatment of their colitis that as long as we're monitoring the liver tests closely and looking out for any new symptoms, I don't have any safety concerns. Another common question in terms of management of PSC has to do with other commonly used medications for the colitis itself, anti-TNF agents. There is very little published experience, I would say, in how the liver responds to these medications when they're given for the treatment of the colitis. But one case series suggested that adalimumab, at least at 6 to 8 months, might have some reduction of alkaline phosphatase, that liver inflammatory test. Although, as I identified there on the slide, that was not sustained to a year or beyond. So my current recommendation, or at least management of patients who have PSC, is that we should watch the liver enzymes closely and watch for any symptoms if any new medication is initiated for colitis. But currently, we don't have yet the tools or the insight to know if this will benefit the PSC itself. So in summary, for pharmacologic management, we're still searching very desperately for effective treatments that can reduce this level of scars or fibrosis, that can reduce the inflammation, and ursodeoxycholic acid has a mixed message, but the colitis treating medications at least appear to be relatively safe with individual monitoring. How about endoscopic management? Endoscopic management is important because over time, many patients with strictures will require ERCPs for symptomatic disease, including cholangitis, from acute obstruction, right upper quadrant pain, or pruritus. Some might be familiar with the concept of a dominant stricture, which is defined as a significant narrowing in the lumen or the opening of a bile duct. It can be present in up to 50% of patients who have PSC, and it unfortunately can be associated sometimes with cholangiocarcinoma. In patients who have symptoms or increased liver tests and a dominant stricture, there is a clear need to open up that bile duct to help the bile flow better. One of the management questions that comes up then is what is the best way to treat these strictures or dominant strictures? Although the practice of endoscopic ERCP endoscopies is not exactly the same between Europe and the US, the largest study to date was published recently from Amsterdam as a multi-center study looking at the best way to open up these strictures. They compared balloon dilation to short-term stenting, and they actually did not fully conclude the study because of futility, which means that they did not see a difference in the amount of time the patient would go then without needing to have a new intervention. They did find increased adverse events in patients who had received stents versus balloons, but the precise way in which the procedure is done is a little bit different, and I can explain that later. But I would say for now, at least, that opening up the strictures is important. It clearly can help the bile to flow better, but the way in which that's done has not been shown unequivocally to matter at this point. Another very hot topic, I would say, is whether there is a benefit to have routine endoscopic intervention for these strictures. It's controversial. Anyone who's had an ERCP might know that at least during the consent process, there's a mention that sometimes there can be some inflammation, pain, post-ERCP pancreatitis, and so we don't take these procedures lightly. And for that, and for the most part is why there is not a recommendation for routinely going in to do ERCPs. One study that was just published or just accepted for publication comes from a group in Heidelberg in Germany, where over the past 32 years actually, they have, when they meet a patient with PSC, they put them on a yearly scheduled ERCP program versus ERCP on demand, which would be if there's complications that require them to go in to help open up a stricture. Interestingly, in their group, in their cohort, they saw that survival was higher in the group that was scheduled for yearly ERCPs compared to those who had it on demand, meaning if there was a need for complications. There was also a reduction in the amount of bacterial cholangitis, which would be an infection of the bile, and there was no difference in the complication rates. It probably should be clarified that the benefit in survival was for those that had a dominant stricture, and it's known that these very tight narrowings or dominant strictures do have an impact on ultimate survival, but they made a case that they were able to identify them earlier and intervene on them earlier. I think that this is not settled science at this point, but certainly it's a recent article that should be debated among the medical community, but also shared with you as patients. How about acute cholangitis itself? This would be characterized by a sudden pain, fever, chills, typically from a bacterial infection. It is the source of some of the sudden symptoms that can occur in PSC. My practice is to ask patients to always be prepared to go to the lab, have lab order on hand, to initially get that as soon as these symptoms occur. Obviously give us a call so we can work through this, we can get some imaging. This sometimes means that there is a need for a procedure or an ERCP to open up the bile ducts. But in some cases, I certainly wouldn't recommend this for everyone, but a pill-in-pocket approach can sometimes work, which is to have antibiotics on hand to already begin antibiotic therapy if the symptoms are very classic while doing that important workup. Certainly not as a replacement for the evaluation, but in some cases this can be helpful. How about cancer surveillance management? We do know that unfortunately cholangiocarcinoma is one of the leading causes of complications, serious complications in PSC. And most centers manage this risk by performing imaging studies about once a year for patients with PSC. Although traditionally this has been lacking in data to support why we do this. Until very recently, once again, the great studies that are performed here at Mayo Clinic shed some light on this. They went back over a 20-year period and identified patients who had had imaging studies to look for cholangiocarcinoma on a yearly basis, I believe, and they found that there was an improved survival by having these imaging studies. It was not fully specific for MRI versus ultrasound, but looking at the bile ducts did have an impact. And I think that just confirms what many of our centers, and I personally do as well, which is regardless of symptoms, imaging of the bile ducts about once a year would be recommended for that reason. How about management, or in this case more monitoring then, of scars or fibrosis? We know that fibrosis, if it accumulates to a large degree, can cause and is the description of cirrhosis, which can then lead to liver decompensation, something Dr. Heimbach will be speaking about when it comes to transplantation needs. So we very much want to be able to know and monitor and anticipate if there is an increase in the amount of scars. Transient elastography, which is also known as FibroScan, has been shown in a study, this was from France, that on a yearly basis, a significant increase in the stiffness level of the liver as managed or as measured by FibroScan can be helpful in the prediction of who is at a higher risk of progressing to cirrhosis. Dr. Eaton is doing the foremost studies, I think, in the US and in the world of MR elastography, which probably has even a better capacity to evaluate increases in stiffness. But when I meet a patient in clinic and we talk about PSC, one of the things I recommend is that we perform probably every 1 to 2 years an imaging study such as transient elastography or MR elastography for this very purpose. I do think it adds some value to the management of the patient so that we can be as informed as possible as to what's going on. I think I'll skip for the sake of time and also because of the lecture that had just passed about bone health management. We can certainly discuss that if there's any other questions, but I think it was very well addressed. I want to conclude then for the next 5 minutes or so on PSC symptoms. This clearly is a very important topic, and while some PSC symptoms such as fatigue are constant or can be constant, many other symptoms in PSC we know are episodic and fluctuating, and that can be a source of frustration because from 1 week to the next, the symptoms can be very different. PSC partners, again, taking the lead on understanding how the condition feels from a patient perspective, has just provided wonderful data that's just been published this month, actually, in CGH on the symptoms in the registry. And you can see the spread there about the percentage of patients who have abdominal pain, pruritus, fatigue, and depression. I'd like to highlight something that was just mentioned in a minor part of the paragraph, but the mean number of missed weeks of school or work over the past year was 5.7. I mean, we know that these symptoms have real-world implications, and I think that we need to be as aware of this as possible. Itching or pruritus, then, is one of the most bothersome complications of PSC. It can be very mild and trivial, all the way to devastating and paralyzing, and everything in between. One practical concern I would always put out there is that new onset or sudden worsening of itching or pruritus should always result in a phone conversation or an in-person conversation with the provider, because we do need to make sure that's not due to an obstruction or a new stricture. Topical moisturizing creams can be helpful, such as Eucerin, my first go-to medication. Again, nothing is right for everyone, but powder cholestyramine taken 20 minutes before a meal can be very helpful for many patients with itching or pruritus related to PSC. And we won't go into details about the other medications that can be used. There's no one-size-fits-all here, but just monitoring very carefully for changes is important. Psychological well-being is increasingly emphasized for good reason. There was a very nice study in PSC Canada which looked at the level of anxiety, and it was about 3/4 in patients with PSC. Interestingly, there was no relationship between some of these symptoms and the degree of inflammation on blood tests, which is always important for us providers to remember, that the symptoms, and even more so the anxiety and the mental health aspects of PSC, are not always in sync with what's going on with the blood work. So we need to be operating on multiple levels at the same time. Which brings us then to the last topic, which is patient-reported outcome measurements, or PROMs. If you haven't heard about PROMs, they are a way of assessing the symptomatic impact of disease by directly capturing the patient's experience without additional interpretation from anyone else, not from a provider, caregiver, but it's directly giving the patient's voice in symptoms. Disease-specific PROMs for PSC have not traditionally been available, and many studies of quality of life in PSC have used more general tools. More recently, though, there was the publication of the first disease-specific PRO or PROM, which is called PSC PRO, a 42-item disease-specific instrument. And I'm not going to list all of the items, but you can just take a survey there briefly. You can see that it looks at two measures, the PSC symptoms and then the impact of these symptoms on life functioning. I would say off the bat that there are some known, and I think increasingly known, limitations to this tool, one of which the patient input into its development could always have been more thorough, I would say. I think in addition, anyone who has colitis might know that attributing a symptom to colitis versus PSC can be challenging, and the colitis impact here was not separated out. And then third, we know that PSC, not only based on age, but demographics, is a very diverse condition in terms of patient experience, but further diversity would need to be present in this tool development and validation. So there is a real need, I would say, then, for a critical evaluation of tools such as the PSC PRO in a real-world setting of patients of various backgrounds, so we can understand what is the symptom burden and the impact of these symptoms on PSC. PSC Partners is funding and co-sponsoring, rather, a new tool which is being developed in the United Kingdom by Doug Thorburn's group, which hopefully will address some of these concerns in the way it is developed. And so I would highlight that as an upcoming development that we should all look forward to. So in summary, pharmacotherapeutic management for PSC is not yet adequately developed. We're acutely aware of that, but we currently use the tools we have, and if we're mindful of what is harmful and what is helpful, we can make the best joint decisions in clinic. Endoscopic management of dominant strictures is important, and the practice is evolving in terms of how and when we go in. Monitoring for fibrosis and cancer surveillance should be performed. Bone health, as was discussed earlier, is very important in management of PSC. Pruritus as a complication should always be assessed, but it should not be ignored. Clearly, we have a lot of tools to address it. And then finally, patient-reported experiences are very important, that we need an area that we need to increasingly pay attention to as providers and researchers. And with PSC Partners and all of your help, I think we're going to make great strides. So thank you for your time.
Thank you, Dr. Assis. That was wonderful. So our second speaker is Dr. Julie Heimbach. Dr. Heimbach is a professor of surgery and previously a director of our liver transplant program. She is very involved at a national level regarding organ allocation policy. She is a friend and a colleague and just has an outstanding clinical acumen, so we're very pleased to have her here today speaking about liver transplantation and organ allocation in 2019. Dr. Heimbach.
Thank you very much, John, and thank you very much to the organization. It's really a pleasure to be here. This is an incredible group, and it is, as all of the previous speakers have endorsed, quite an inspiration to be here and to meet with all of you. We spent an hour yesterday actually on the topic of liver transplant. We had a lot of questions and a lot of engagement. So today the focus is really going to be on organ allocation in 2019, and as you're going to hear, there's quite a lot actually happening in this, so we'll have 20 minutes to talk about that. Covering the idea of the MELD allocation system, what does it mean to have a MELD exception? As some of you may or may not know, we're in the process of switching from a regional to a national review board for patients with exceptions and looking at a broader distribution for organ allocation in general. So whenever we speak about organ allocation and really transplant in general, it's critical to consider this in the context of the wait list. If there wasn't a wait list, half of probably what we talk about in transplant would be able to go away. But unfortunately, there is a wait list. There's just not nearly enough organs for the patients who need them, and more than 100,000 people are currently waiting for a transplant in the United States. Importantly for liver, right now the number is 13,159, and actually I'm happy to say that since I started my job, this is the smallest number I've ever been able to put on the slide, and the biggest number that have ever been done in terms of transplant at more than 8,000 last year. So that's huge actually, and I'm actually very excited about that. But still, you can see that those numbers don't match, and there's still a gap. And unfortunately, when we look at what happens to patients who go on the list, we're still not seeing all of those patients getting to transplant. What we're seeing when someone went on the list and stayed on, following those patients over 3 years, if they went on the list in 2014, what would happen to them? And you can see, a big number of them do get transplanted. So, about over half, 55%, do get transplanted. Unfortunately, about 20% have to be removed in that 3-year period because they became too sick to be transplanted, and 13% died while they were waiting, while the remaining are still waiting, and that's about 20%. So how do we make these decisions? What happens with organ allocation? So, of course, as you know, transplant is the standard treatment for a patient once they have liver disease. Their liver's not working anymore, decompensated, meaning they're having symptoms. And ideally, we would be able to go forward to transplant, essentially to every suitable recipient as soon as they needed the transplant. But unfortunately, because of the shortage, we can't do that, and so we have to choose who is going to go next. In the ideal world, that system would be transparent, meaning everyone could look at it and say, yep, okay, that's clear, I understand how that works, and that we would balance the idea of the patient who most needs it, but also the patient who's also going to benefit. You don't want to transplant a bunch of patients who are not going to do well. On the other hand, someone who's doing pretty well on the list is also going to do well after transplant. So you need to choose both urgency and benefit. They both need to be part of the equation. And right now, the equation in the United States is this complicated thing you see up there, which is the MELD system. And I'm sure that most of you who are facing transplant well understand that this is a model that does use standard labs that we all get when you come to the clinic, and we can put those labs into a formula, and that formula can do a pretty good job of choosing which patient is most urgent, at least from the standpoint of their liver disease, over the next 3 months, who is at most risk of dying from their liver disease in that time period. And so the labs we currently use as are highlighted up there in the red, so 3 labs we've been using for a long time: creatinine, bilirubin, and INR, and then recently adding the sodium. The benefit of adding the sodium actually has shown that we're even better at picking which patient is at risk. And so by picking the sickest patient, we're reducing the chances of death overall on the list, and since we've started adding sodium, the risk is 26% lower for waitlist mortality, so that's a good step forward. So the strengths of this system, well, first of all, it does fit with what is called the final rule, and this is actually a federal law that says how we have to allocate organs, so it's good to follow the law. It doesn't work out very well if you don't. And it picks the patient who is sickest. And when we added the sodium, that modification does accurately predict the waitlist mortality. And it's relatively easy. It would be hard if we had a system that had, even more arduous way that you had to update it every couple of weeks. Obviously, getting a blood test is not easy, but it is a blood test that we can run with ease in basically every community. And the system also includes this idea of an exception for certain complications of liver disease, like if you get hepatocellular cancer, which is a very common complication of liver disease, or hepatopulmonary, which is a sort of a less common problem that can happen in liver disease and can increase the risk of a problem on the list, not necessarily related to the cirrhosis, but as just a complication that can happen because you have cirrhosis. And that complication is going to increase your risk of having a problem different from how your liver itself is functioning. So we have to have a way to handle those patients as well. And so we've actually got a list of the most common, and they're called standard exceptions, and patients that have one of these conditions automatically get this exception. So their waitlist priority is not managed anymore by their lab tests, but rather because they have this specific problem that is related to their cirrhosis. And the vast majority, more than 2/3 of exceptions, are granted for hepatocellular cancer, so that's why that's in bold. Relevant to this particular audience, I've also bolded cholangiocarcinoma because this is also a standard MELD exception, thanks primarily to the work of Dr. Gores and a lot of other people working with him, but that's why that's on this list, and so that's important. So that's kind of the basics. Now, how have we gotten off the track with this system? What are some of the issues? Well, first of all, there's some patients that have a need for other kinds of exceptions. They're not fitting into any of those standards. And so we created a system throughout all of the different regions, the areas of the country that are organized around organ allocation, so that those boards could consider things that don't meet these standard policies. And about close to a quarter of the exceptions are for these non-policy-based things. The problem with that is that the regions were inconsistent. You can get a score in one region and not a score in another region, and there's a wide difference in the scores that are granted, as well as what that score means. A score of 25 means something very different in one area of the country compared to another. And so now, since May of 2019, we actually have switched to a national system for review rather than the regional system. And there are guidance documents that have been created so that we can have increased consistency around the country. We've also moved to a different scoring system, and that is currently based on trying to recognize the fact that around the country there is a different score that is needed to access transplant. So rather than everybody starting at the same score and going up every 3 months, we're now also going right to that median score, whatever that is in the area where you are, and then just a little bit less than that. So for non-standard diagnoses, that all these sort of extra things that aren't based in policy, there are now guidance created around, should you get an exception for this, should you not get an exception? And so on the list of things that may be suitable, there's a pretty big list there you can see. Relevant to this audience, patients with PSC who have biliary sepsis, so that means the severe kind of infection that can happen from a blockage, that increases your risk of having a bad problem on the list, different from just how your liver's functioning day to day. So if you're coming in the hospital with severe life-threatening infection, that would be a reason that you would need to have a score adjustment. Generally, all the other things that just fit with having cirrhosis should be predicted by the MELD score, and there would not be reason to give a special score for that. The system has been divided into a variety of different components. So the pediatric group is reviewed by a group of experts in pediatrics. Patients with HCC, hepatocellular carcinoma, are reviewed by a group because it's such a big group and there are special nuances to that, and then everybody else goes to a separate board. How are we going to assign scores? Because as I already told you, around the country there's quite some difference. So as I already mentioned, we've eliminated the idea of the elevator. And why have we done that? Well, a couple of reasons. First of all, it's probably contributed to the sort of global or the across the country escalation over the last 10 years in the score that a patient needs to have to access transplant. So patients who don't have an exception have had to get over this threshold system created by this continuous elevation of scores, and has led to a significantly higher waitlist mortality for all of the patients that don't get one of those problems. It's a strange feeling that, this is the only time in your life that you want to get cancer is when you need a transplant, but that's sort of a well-known observation because we had over-prioritized the patients that had developed hepatocellular cancer so that they could move ahead of the patients who were just suffering from liver disease. So I've been trying to adjust that for quite some time. And so we know that without that adjustment, patients who don't have exceptions are continuing to really struggle, and so this is aimed at trying to balance that out. And so what is happening is that the patients are now going to be assigned a fixed point. Right now it's going to be set at 3. That might need to be adjusted, but that's where it is right now for pretty much all of the standard diagnoses with one change, which is oxalosis. That's a particular metabolic condition that is quite rare, that gets a little bit higher score. And overall, the goal is to try to balance the needs for transplant for patients with and without exceptions. I will make a point that I think patients with cholangiocarcinoma might also need to have an adjustment, and hopefully, we can advocate together for that to happen. But going forward, as we watch this, additional issues, significant geographic variation in access to transplant. This is really still separate from the review system or the exception system, still a major challenge. This is a map of the United States, and what you can see is over time from 2010 to 2017, overall, there has been a shift. Every one of these places, a higher and higher score that you need to get to transplant, but there's also quite a difference. So that spread goes from a low of sort of 19 to 20 up to 36. And the waitlist mortality for a patient with a score of 36 is extraordinarily high, in the neighborhood of 75% over the next 3 months, compared to somebody with a score of 20, which, it's probably in the range of about 8%. So it's a dramatically different risk of dying on the list across the country, depending on where you are. And so that's still an issue that we're trying to struggle with and trying to make change on. We've actually been working on this pretty much nonstop, actually, since 2013, which is rather remarkable. We've had 3 national forums, 3 cycles of public comment, modeled more than 150 scenarios, if you can imagine that. And we actually did pass a policy in December of 2017, which would have utilized the existing system of regions that we have in place now. There's areas around the country broken up into 11 separate regions with smaller units called DSA or donor service areas. So you can sort of think about that as like counties and states. And so there's a smaller area of allocation and the larger area of allocation. And so what this system did was preserve that and just make it a slightly bigger, adding a circle around the donor hospital so that whole regional area got just a little bit bigger. And that did make some positive change. But that system didn't go far enough for some people. They thought that just wasn't a big enough step and felt that it wasn't actually consistent with federal law, which is called the final rule, which is where we're supposed to minimize the impact of geography. And since regions and the smaller area of DSA were never actually originally designed for the purposes of organ allocation, that really just didn't meet the legal standard of why you're using this. If it's not perfectly designed for organ allocation, we shouldn't use it. So there actually has been a ruling to say that we shouldn't use it, and so that's gone. And we passed that and we got rid of it before we ever implemented it, and we were asked in June to do it again in a much shorter time frame, not taking 6 years, but rather taking 6 months. So that was hard to do, but that's what we've been working on. And what we wanted to then do, since the region system was not optimally designed, look at maybe a circle, and ideally it would have been a population-based circle, because as you can see on that map of the United States, there's different, that's a map showing population density. Obviously, there's differences. We all know, those of us that live in the sort of West and the Midwest, that there's many areas where there aren't any people, and that's as reflected in the white there, and it gets more dense as you head to either coast. So a circle around Cheyenne, Wyoming is going to be very different than a circle around Boston, for example. So making a different size circle would make sense, but there just wasn't time to accomplish that task in the time that we were given. So we did a surrogate for that, which is this acuity circle model, a very big circle for around the donor hospital. So any patient listed at a transplant center within a certain radius around a hospital that has a donor, that's how it would be allocated. Very big circle for status 1 patient. That's a patient who has an expected survival of less than 7 days. And then it goes back to a small circle for the most sick patient, 150 miles around. And then if there's no really sick patient with a score of 37 to 40, the circle gets a little bigger, 250 miles. Again, 37 to 40. Still no patient, then it gets a little bigger, up to that 500-mile circle. Then if there's nobody in that sickest category, it goes down to 33 to 36, 150, 250, 500, down all the way to 28. So what does this do? Well, practically speaking, you can see if those dots in the very center, which are green, and then this grayer and less gray circles around there, showing you those different radiuses of distribution. And what that means, basically, the other colors that you can see, say Minnesota is in pink there with North Dakota, South Dakota, Illinois, and Wisconsin. That's our current region 7. These circles will show you how organs are going to be distributed differently under the new system. So the green dot represents, again, the donor hospital. And then ultimately there's that 500-mile circle. So quite a bit more sharing than we're doing now. And how will that help us? Well, you can see we've measured a variety of different things that are shown on this table. The first column shows what are the different systems. So the top is current. That's what we're doing today. And then in the thing that we approved in the board of 2017 that we approved, we never implemented, we got rid of that. And then the acuity circle model is the one that we've most recently approved. What do those do? Well, the first column says variance in the median allocation. What that means is the difference in what your score has to be depending on where you are in the country. We would like that to be 1. We'd like it to be no difference. But right now, it's very different, 9, almost 10. The new system will go down to 4, which is good. But we're going to have to travel more. You can see those circles are bigger. So the time to fly the liver will change by just a little bit. It should not make any difference. But it will cost more to fly around more. So instead of flying only 50% of the time to do these organ allocations, we're going to fly almost a little bit more than 70% of the time. But that will reduce the chances of patients dying on the list. So that's the big benefit. It will get more fair, and it will have less patients dying. You can see the current system there with all the different colors. You can see quite a bit of variation, and all getting closer to blue, showing less variation under the new system. So what did we do? Well, we did pass this acuity circle model in December of 2018. We were going to implement, but yes, we've had another lawsuit, so now we're waiting. And we have gone live with the NLRB, but the broader sharing policy is on hold because of lawsuit. And we're not going to get into the details of that, but I would say over the next 1 year, that should hopefully be worked out. It's hard to say how that will be worked out, but that's the current status. So to summarize, the MELD allocation system prioritizes livers to the most urgent candidates. There is a system of exceptions that is needed to account for all these other things that can happen to people when they're on the list that are not captured by that system, which currently is MELD. That system is generally working, but the inconsistencies made us switch to a national rather than a regional oversight board. Efforts to reduce the sort of geographic inequity is ongoing, and change, I think, is difficult. And for this group, important to know, I think advocacy is a very central part of this process of change. And, I think looking forward to working together with this organization, specifically around the issue of cholangiocarcinoma. Thanks.
Thank you, Dr. Heimbach. Okay, moving to our third and last speaker for this session before we go on and take some questions is Dr. Aliya Gulamhusein. She comes to us from Toronto, where she is an assistant professor of gastroenterology and hepatology. There, she is the leader of the autoimmune liver disease clinic and sees large numbers of patients with PSC. She's actually one of our former graduates from our transplant hepatology program here in Rochester, and is also a prior recipient of the Young Investigator Award from PSC Partners Canada. We're really excited for her to be here today and talk to us about busting myths that we all commonly hear from our patients with PSC.
Good morning or good afternoon, everybody. Thank you very much to the organizers and to all of you for being here and for inviting me. This is a true honor and a privilege. We do what we do because of all of you, and so to be able to share some of our knowledge and our experiences with you is, as I said, a real privilege. So I've been tasked with the lecture title including primary sclerosing cholangitis and myth busting. In terms of an outline, we'll talk a little bit about symptoms in PSC. As we know, these are common, but it's often thought that patients with PSC or liver disease in general do not have symptoms. We'll talk a little bit about why there's misinformation around these issues. I'll spend a little bit of time discussing myths around liver transplantation and cholangiocarcinoma. We'll talk about prognostic models and how we can use some of them to understand risks, and then strategies for continuing on educational efforts to keep these myths debunked. I could not resist the opportunity to talk a little bit about Canadian myths, because I know that there's a big Canadian audience here. So we'll do a few Canadian mythbusters for the audience. So if anyone's watched Anthony Bourdain's Parts Unknown, you might think that this is how we live and this is how we eat. And that Canada is this place in the North Pole where everyone wears parkas all the time and lives in igloos. But if you actually look at it, Toronto is south of Rochester and south of Minneapolis. Essentially, we're in Beachland. And you might think, who thinks that who has this impression of Canada in terms of sports? Yeah, that's what I thought. But anybody who's been in Toronto in the last week will know that rather than being a hockey town, we're much more of a basketball town. And that's actually a picture of downtown Toronto during the Raptors parade last week, which was a bit of a zoo, but fun nonetheless. Okay, so let's talk a little bit about what I'm here to speak about. So symptoms in PSC. I often get told that patients will say that people tell us we're not supposed to have symptoms, but we do. And this is data that was just published. Dr. Assis mentioned it a few minutes ago, but published out of work from patients that tells us exactly how many patients actually have these symptoms. So between 30 and 70% of patients present with symptoms of itch, jaundice, fatigue, depression, sleep disturbances, abdominal pain, and diarrhea. And this is data from you. We wouldn't know this. Sometimes physicians don't ask enough about it. Sometimes patients don't report it because they feel like these symptoms are normal or what they should expect. But when you ask about it and when you put it in proportions, 30 to 70% is a big number. And then patients will say that they've read literature to say that I only have 10, 15 years to live, and they're worried about their ultimate outcome being ending up in an operating room with a talented surgeon like Dr. Heimbach we just heard from, or they'll end up with manifestations of decompensation, being jaundiced and having complications of portal hypertension. And it leads to these circular, vicious thoughts of catastrophe. Every symptom is associated with this potential outcome, and could I be heading in that direction sooner than I want to be? But I think when we look at literature and we look at epidemiology, we have to understand why these proportions and why these statistics are there. And so understanding epidemiologic data is really important. PSC, we know, is rare. And because it's rare, it's often studied in very highly specialized centers that have enough patients to study it well. But inherently, specialized centers have sicker patients, because sicker patients are referred more frequently to these centers. And this can result in an important bias in the literature, as well as in the popular media, which is really readily accessible. And minimizing bias in the literature is really important, and that's one of the important things that academics need to work on. This requires, especially for rare disease, large-scale international collaboration, which requires patient contribution, and this organization has done such an amazing job with helping us with this. It requires academic interest and engagement from centers all over the country, and all over the world, and it requires time. I'll spend a little bit of time talking about some of these international efforts that have allowed us to make headway in the field of epidemiology, particularly as it relates to PSC. So the International PSC Study Group is a large international cohort that has developed an adult cohort of more than 10,000 patients from across the world, from 37 centers in Europe, North America, Australia, Asia, and South America. And there's another pediatric cohort that has accumulated data from more than 780 patients from countries around the world as well. And with this robust information, we're able to understand epidemiologic trends that are more than just from within single centers. So these are survival curves that many of you might have seen over the course of the last several talks, but if you look at time zero, there's 100% of patients surviving, which is what you'd expect, and that number decreases over time, as we know in patients with PSC, but it never actually hits zero, at least in these trends that have been reported. And what we see when we have lots of patients and we can study them in big numbers is that not everybody reaches an outcome at 10 years or 15 years or 20 years even. In fact, 63% of patients in this large cohort from the International PSC Study Group were transplant-free at 10 years. And that differs based on patient's age, as you would expect as well. So when you have big enough populations to study these trends, you can look at different subgroups and get a little bit more granular data. And you can see that even after 20 years, 37% of patients were transplant-free. So it's not an ultimate outcome for everybody. We know we have a lot of work to do to improve these outcomes, but it's not a guarantee for everybody. And a lot of the misperception also from epidemiologic work relates to how risk is reported. Statistics can be reported to give any sort of message that you want them to, and absolute risks are very different from relative risks. So if you see here, an absolute risk sort of discusses the proportion of patients that have a certain clinical event, and a relative risk looks at that risk comparing between groups. So the differences in these risks can be reported. So for example, if you see this absolute risk in the cohort on the in one of the cohorts says 2 out of 10 patients have a clinical risk. So that's about 20%. If that risk increases to 3 out of 10, that's 30%, but that's actually a 50% relative risk. So depending on how you report outcomes, you can make the difference seem more pronounced than it actually is. And that's one of the issues that we see when we talk about cholangiocarcinoma risks. So the relative risk of cholangiocarcinoma in patients with PSC is high. We know that. That is something that we all worry about. But the actual absolute risk is much smaller when you report it as an absolute rather than a relative risk. So this is, again, work from the International PSC Study Group that shows, again, at time zero, nobody has the outcome. And over time, that outcome increases. It's much, much higher early on in the first couple years after diagnosis. But even after 10 years, 89% of patients are malignancy-free. And when you look at it by ages, that's different as well. So older patients have a higher risk of outcome. But after 20 years, a significant proportion are still malignancy-free. So there's work to do. The outcomes definitely happen. But sometimes when you parse out the details, the risks seem a little bit less than we worry about. Parents have a tough job. When you worry about pediatric disease and PSC in specific, I mean, the anxiety is almost inevitable. So then we want to understand what the risks are in pediatrics as well. And the pediatric group headed by Dr. Deneau looked at this cohort of more than 780 patients, pediatric patients, and looked at the risk of outcomes for them. So they looked at an accumulation of events, including portal hypertensive complications like ascites and variceal bleeding, as well as biliary complications, cholangiocarcinoma, liver transplantation, and mortality. And you can see here again, at the top, at time 0, nobody has an event, and that event rate increases over time, but still it's not complete at 10 years, and there are a good number of patients that don't reach these outcomes after even up to 10 years. And here you see that there's a 70% event-free survival in children after 5 years of diagnosis, so that means all those events combined, and a 70% survival with the native liver at 10 years in children. So there is hope that these things won't happen over the course of these periods of time. But it's natural to think, I mean, these numbers don't reflect me. What about my specific risk? And some patients will tell me that I don't understand how to make this relevant to my situation. What's going to happen directly to me? We know in PSC that individual risk is highly variable. Disease fluctuates and it's unpredictable, and that's one of the big challenges. But there are models that have been developed to guide risk. They're not perfect, but they're there to guide us in our discussions with patients. And they're informative, like I said, for patient discussion, but they're certainly not set in stone. This is a list of a few of the risk scores and models that are available to patients online that you can use and that we sometimes use in the clinic, including the Mayo risk score. There's the Amsterdam-Oxford score that was developed obviously out of Europe. There's the UK PSC risk score, and there's a Presto score that was developed here at Mayo. And this is just what the Presto score looks like online. I've been using it in the clinic fairly frequently now, and I included a link. I'm not going to go to it right now, but it's something that patients can use and clinicians can use by putting in easy variables on about their history and about their blood tests, and it can predict a risk of outcome over a period of time. The Amsterdam-Oxford score is also available online and can be accessed by anybody through just their website. You can just Google it and you can find them. And it can give you a guide about risk of outcome over the course of a period of time. And while it's not perfect, and models, like I said, are not perfect, they can help guide discussion and perhaps alleviate some of the concern about one's individual risk in a period of time. But importantly, no predictor is perfect, and we know that. We have to make case-by-case discussions and have individualized discussions with patients. But information is certainly power. I think it's important to remember that individuals behave much differently than models can predict. Google is sometimes helpful, but not always helpful, and it can give misleading information. Talking to your physician and keeping an open line of discussion and open lines of communication with your physician is really, really important. And finally, engaging in research. I think it's important that we emphasize that the more we learn, the more we know, and this organization is a perfect example of how much progress we can make with patient engagement, advocacy, and input. And I'll stop there. Thank you very much.
Thank you, Aliya. That was wonderful. I'd like to invite the other speakers to come up and please have a seat, and we'll take your questions. I think somebody should be around to pick up some cards. Okay, great. So we have a few questions. So this one is for Dr. Heimbach. So does the MELD sodium correlate well with the severity of disease in PSC patients where the liver is not so damaged and the MELD doesn't always rise proportionally to the severity of how they're feeling?
Yeah, so that's a great question, and we talked about that quite a bit in the session yesterday, that unfortunately you don't get any points for suffering under the MELD system. And so really the endpoint is a pretty black and white endpoint of death, mortality. And for patients with PSC, MELD sodium is still quite predictive of that specific endpoint. but not specific for the other things that can happen, ascites, encephalopathy, all of the things, itching, horrible complications that lead to a lot of suffering. And patients with PSC do tend to be younger, and they tend to have less of the other impacts that increase mortality, like renal failure and other complications. So they tend to survive, but because they're surviving longer, probably they're also suffering longer.
Thank you. Okay, next question is myth or truth? If I have PSC in early stages, it's slowly progressive. Is it okay to have alcohol in moderation, or should somebody with PSC always avoid alcohol?
Ooh, this one might be controversial. So I think that we are physicians, but we're also people, and we understand that there's a balance between quality and quantity. And my approach is generally in patients who have cirrhotic stage disease, I think abstinence from alcohol is really, really important. In patients with early disease with minimal fibrosis, I say you have to be conscious of the fact that you have PSC, which is an underlying liver disease that's not reversible. And 2 insults onto your liver is always going to be harder than 1. So you have to be careful, and you have to be moderate, and be conscious of the fact that you're dealing with another underlying reversible process. So in patients with minimal fibrosis, I say that you don't have to be completely abstinent, but you need to be very careful.
Thank you. Okay, next question is, what can we do to help advocate for a, quote, opt-in organ donation standard, and where should we start?
So that's a great question, and it relates to the idea of right now, people can indicate that they wish to be an organ donor, and so that's the system that we have right now. And in other countries, a couple of other countries around the world, it's presumed that everybody wants to be an organ donor, and you have to choose to opt out. And the reason that has not been adopted in the United States is probably centered around the concern, of that might have the opposite effect, that everybody would be worried that, people are just going to steal their organs and they're not going to care for them when they come in with a critical illness. And so there could be a large number of people that would actually select not to be an organ donor if they felt that their individual liberties were going to be harmed. So I think there's a controversy about this. It's definitely something that has been discussed a lot. Would that really increase organ donation? It's hard to actually know that answer, because families could always override that decision. So it's hard to know, really. I think the more important thing would be to continue to advocate to get everybody to indicate their wishes, because that really makes a huge difference to help families make a decision in this terrible moment where their loved one has had a devastating injury, wondering about what to do with organ donation. If the individual has already indicated what they want, it's very simple for the family. They don't have to think about it anymore. And it just takes so much pressure away from the family. So I think that's where we should put our effort at this moment. The other effort is also valid and one to think about, but whether it would really move the needle or not is uncertain.
Okay, so 2 questions for David here. So what's the most common, quote, pill in a pocket? So referring to antibiotics and cholangitis that you prescribed. And second, is cholestyramine preferred over cholestyramine for pruritus?
Sure, good questions. So, as I said during the talk, I always hesitate to give advice that can be used, indiscriminately, because every patient is different, every circumstance is different. But we know that the type of bacteria that typically get into the bile ducts that cause cholangitis are what are called gram-negative bacteria, for the most part. And so typically, in my own practice, it's ciprofloxacin is an antibiotic that I sometimes give patients and ask them to hold that and to start taking immediately if they feel unwell. But once again, I always qualify that just by saying that there are some circumstances in which that's not appropriate, but on an individual level, typically that is my go-to, with a lot of caveats for specific circumstances. And then in terms of cholestyramine, I believe the data is a little bit better for the powder, the cholestyramine being effective. Clearly that's not tolerated by everyone, and there are various different regimens. I will try cholestyramine if cholestyramine is not effective. But the timing, if there's one very practical advice, I feel that the timing of cholestyramine is important. It's there to bind bile when bile is excreted into the intestine. So if you take that cholestyramine after a meal or even during a meal, it's a bit too late. Classically, it's 10, 20 minutes before a meal. It should be ingested so that it's in the intestine as the bile is secreted. And so I feel like the way in which you take the medication is just as important for how well it works.
Yeah, that's a great point. A number of questions that are transplant related, specifically in regards to age. So, in age limitations for either being a living donor, age limitations for the cadaveric liver organ donor, limitations on age for recipients.
Yeah, so we'll take those in the order that I heard them. So the first is a living donor. If you would like to be a living donor, is there an upper age limit? So it's important to understand about living donation. The reason that this works is that the liver is growing back again. So it relies on the possibility that the liver can regenerate both for the donor and for the recipient. We know that this process slows down as we age. So yes, there is an upper age limit for somebody to be a living donor because it becomes less safe for the recipient and especially less safe for the donor because it doesn't grow back as quickly. It still grows back, but not as quickly. So what is that number? Of course, it's an arbitrary number. We know that the risk gets higher the older that you are, so we've drawn a line at a certain specific area. Depending on which program you go, that area is somewhere around 55 or 60. In terms of the upper age limit for deceased donation, that's quite a bit different because the liver does not typically need to grow because we're not dividing it in half. So we would give you a size-appropriate liver. We don't need it to grow back. Even a liver from someone in their 80s is a beautiful graft, depending on, how that individual's other, health was. If they didn't have a lot of extra problems like, being very heavy or having diabetes or other conditions that may affect the liver health. So we commonly use livers from individuals who died in the 80s, and they're beautiful sometimes. Sometimes they're not, and then we don't use them. I would say the biggest issue about those is we would go out for the recovery. We might find that it's not suitable. The potential recipient has come in for the transplant, and it's very sad because you're ready to go, and we're like, oh, the liver's not any good, so we can't go ahead. So that is more likely to happen when we go out for an older donor liver. The last question is, what about a recipient? Of course, again, age is a number. There are people who are in their 50s who have many things wrong, with their health besides just their liver. Those patients may not be suitable to be recipients. People in their 70s who just have PSC, no other significant medical problems, could be great candidates for a transplant. So we have to consider the whole picture. Obviously, we all get to a point where, there's an end. And so the closer you get to that, the less benefit there is to having a transplant because the other parts are not going to work for the long term. So there is a number, but it varies depending on the patient. It's not a specific number.
Thank you. Next question is, can cholangiocarcinoma be identified on non-invasive imaging at an early stage as compared to an invasive test such as an ERCP? David or Aliya, do you want to take that one?
Sure. Well, I think the diagnosis of cholangiocarcinoma, especially, as Dr. Heimbach, I think, had mentioned, if transplantation is a possibility, is something to be tread carefully. But for starters, I think, as I had mentioned, that there is some benefit to screening. So imaging studies are beneficial in my view, and it's common practice in most major centers to have an imaging study of some kind, either for symptoms or just on a yearly basis. And so that would be the first level of imaging to determine that whether there is something of concern. Typically, a tumor will enhance, and that along with some changes to the bile ducts on an imaging study can raise an initial level of alert. After that occurs, or if that occurs, then there needs to be a very close discussion, typically in our center at a tumor board, as to what's the best way to make the diagnosis. ERCP, clearly with a direct access to the biliary tree, and sampling can be very important as a way to get the tissue. I think it gets a little bit more complicated if you get into certain areas of the liver, particularly the hilum, which is where transplantation sometimes can be offered if the tumor has not been accessed through the skin, and there are some protocols for that. But I would say that non-invasive determinants of cholangiocarcinoma are helpful, but typically tissue is relied upon, with some exceptions in which a hepatectomy would be done as well.
So generally, yes, MRCP is an excellent test and is reasonably sensitive, although not perfect at detecting early stage cholangiocarcinoma. The diagnosis often does still remain challenging at distinguishing a benign stricture versus early cancer stricture on imaging. It can be tricky, and often an ERCP with biliary brushings is needed, but using a non-invasive imaging test such as an MRCP up front is often the standard approach and standard of care, as Dr. Assis outlined. Next question is regarding just differences in the Canadian organ allocation system and MELD exception points as compared to what Dr. Heimbach had mentioned.
There's not that many differences overall. I mean, at least in Toronto, we use the MELD sodium score as to prioritize organ allocation, and there are exception points that are identical to what Dr. Heimbach outlined. Exception points for bacterial cholangitis are something we talk about not infrequently, but are given very infrequently. So I think that symptoms in PSC are a big challenge, and prioritizing patients for liver transplantation based on symptoms has not been something that we've done very frequently. But otherwise, the allocation process and the exception criteria are the same.
Okay. All right. Dr. Assis, are there any strategies for doing an ERCP in somebody with altered anatomy or a history of a Roux-en-Y gastric bypass?
It's an interesting question. It can be quite challenging. Oftentimes the advanced endoscopes are not able to access. It all depends on the reason for why there is a need for the test. Percutaneous access of the biliary tree, which is done by a radiologist called interventional radiologist, is one way to access the biliary tree if needed for a blockage, for example. If that cannot be traversed, usually using the ERCP, which is more traditional. I've had one or two patients over the years who, even without altered anatomy such as gastric or Roux-en-Y surgery, just the stricture is too tight and there's a major blockage. And so it becomes a group decision as to how to proceed, but we go to our interventional radiology colleagues for any issue that needs to be dealt with that we cannot approach with the ERCP.
And sometimes you can get extra fancy and do something called a rendezvous, which, eventually would avoid having the tube coming out the side, but, working from the inside and the outside to come together and eventually move the tube to the inside, because obviously having a tube coming out of the side for the long term is not necessarily, optimal for comfort.
Certainly adds technical challenge, can be accomplished, but often at highly specialized referral centers. Okay, another one for Dr. Assis. What, if any, monitoring should be done in regards to post-transplant care? What is the approach to that?
Yeah, post-transplant care is a very interesting topic in PSC. I know that we do know that there is a recurrence rate of up to about 20%, I think, as was mentioned in the earlier sessions. The care for someone who has received a liver transplant should be done in coordination, I'd say, not only with the transplant surgeon and the transplant team, but also with the person who's taking care of the colitis. I think very practical advice I would give, and without getting into too diffuse of recommendations, is that the single thing I've noticed the most that is hard to maintain, or at least is a challenge often after transplant, is the care of a colitis flare. For many potential reasons, not only is there a focus on maintaining the new liver, but sometimes the medications and the adjustment of medications can predispose oftentimes to a flare of colitis. And although I don't think any of us can say with certainty what are the key predictors of recurrence of PSC, there has been suggestion in some studies that active inflammatory bowel disease after transplant can be a risk factor. So one practical advice is to take extra care of the colon after a transplant. Aside from that, standard management of immunosuppression, very close look at any biliary abnormalities, particularly if they're outside of the anastomotic area, would be relevant.
Thank you. Okay, so the next question, and Aliya and David, you may want to tackle this one. After 5 months of vancomycin therapy, my son went from practically quote, stage 3 liver disease to no scar tissue in the liver. Does he continue to be at risk for cholangitis? Will the damage to the biliary tree continue to progress?
It's difficult to know. I mean, there's a lot of work going into finding treatments that we know could be effective for PSC that are beyond UDCA, like Dr. Assis mentioned. Vancomycin has some early literature to show improvements in blood tests, but that improvement in blood tests may not correlate with improvement in outcome like we saw with URSO. And it may not change the degree and severity of the stricturing, which is a different type of progression in contrast to the biochemical changes. Also, non-invasive measures of fibrosis in patients with PSC, like FibroScan testing or MR elastography, can fluctuate over time based on degree of stricturing. So I think it's difficult to know how, or it's difficult to measure changes in progression from a fibrosis standpoint in patients with PSC. Certainly, patients will tell us that their liver numbers have improved on vancomycin, and I think one of the challenges and one of the reasons that we're emphasizing that we get good studies in this disease with new therapies are that we don't know how long to use these therapies, right? And long-term use of vancomycin for years has the potential of changing a lot more than just blood tests. And so until we understand long-term outcomes, I think that it's important that we study these therapies in a robust way. We learned a lot about URSO when we studied it properly. And so I think before we move on to using newer therapies that haven't been robustly investigated, we need to know that we're not doing harm. And so it's one step at a time. Sometimes it's slow, but doing robust randomized trials, I think, is really important.
Yeah, and I'll add to that, it's an important area of study, and Mayo Clinic, Rochester, Florida, and Arizona will all be conducting a randomized controlled trial with vancomycin to help better answer those questions with vancomycin and PSC. Okay, so Dr. Heimbach, are you ready? I'm going to rapid fire a few transplant questions. First, is there a possibility for, quote, round-robin liver transplants?
I think this is like a paired exchange is what you're referring to potentially, and there is that potential. It's logistically much more challenging than what we've been doing in kidney, but it's definitely something that many centers are, including ours, just starting to figure out how to do. We've had a huge success with that in kidney and over the very last 5 years, and it's going to be liver next, I would say.
Okay. Living donor liver transplant numbers appear flat. What accounts for the recent jump in the number of annual transplants and reduction in waiting list time?
So actually, living donor is going up slightly over the last 2 years. Deceased donor is going up more over the last 3 years. A lot of attention has been paid to the opioid crisis, and the contribution of that specifically to the increased numbers of people who die in a way that allow them to be organ donors. There are many other reasons as well, though, but that's a part of it. People that overdose on opioids frequently can be resuscitated, but they're brain dead at the point that they're resuscitated, so that can be, it's very sad, but that's a part of the reason. Other reasons are the increased number of people that have indicated that they want to be organ donors, so consent rates are up, not in every area, but in a lot of areas. I think that has to do with a lot of different reasons, best practices, and just a sort of greater awareness, continued efforts on behalf of really everybody to understand the importance of organ donation. I think you just can't overestimate that, because it was so stunning to me that even in Rochester, which, 70% of the people here work at Mayo Clinic, I'm out on a run with my friends, and they're saying, well, no, I wouldn't sign my organ card because I don't want them to treat me differently when I go to the emergency room. I'm like, what are you talking about? So there is just just a wide misperception in the community. Even people that you would think would not have that perception. So it's very important.
And last rapid fire question for you is, can you comment a little bit about waitlist mortality in general, and specifically what percentage of patients with PSC die while waiting for transplant?
So the likelihood of death on the list for patients with PSC is, reflected by the MELD score. So the MELD score does work in patients with PSC, but as I mentioned, they can wait a lot longer than other patients and have a significant amount of morbidity, meaning suffering, meaning, continued problems. So I think, that it does work. So there have been numerous studies looking at PSC and whether they are, specifically disadvantaged, and it really depends on how you measure disadvantage. If we use the specific endpoint of mortality or death, they are not disadvantaged, but of course, if you look at other things like, number of interventions and hospital stays and all of those things, they would, I think, suffer more than other patients.
Okay, we'll let Dr. Heimbach catch her breath. For Dr. Assis, low-dose naltrexone, is it safe to use and efficacious for patients with PSC?
I have used it successfully in several patients who've had significant pruritus or itching. You always need to look at the metabolic status of the liver. Sometimes with advanced disease that can be an issue, but in principle, yes, I think that can be used.
Okay. Dr. Assis or Dr. Gulamhusein can take this. Is pediatric PSC considered a different phenotype from adult PSC? Good question.
Pediatric, one of the first things you learn in medical school is that pediatricians tell us that children are not the same as small adults. And so I think that pediatric PSC can have a different phenotype. There is a subtype of pediatric PSC that's termed autoimmune sclerosing cholangitis, and it's associated with a significant inflammatory burden. And I think in the pediatric world, they are more inclined to treat patients with autoimmune sclerosing cholangitis with immunosuppressive therapy, be that with prednisone or immunosuppressants like azathioprine. So I think pediatric PSC has different subtypes, as adult PSC probably does as well, and so we can't assume that it's the same process. When we see patients transition from the pediatric age group into the adult clinics, we see these differences, and at times we continue them on immunosuppressive therapy. This autoimmune sclerosing cholangitis phenotype or autoimmune hepatitis overlap with primary sclerosing cholangitis is more so what we see in the adult population, but that's just in a minority of patients.
From my standpoint as a provider for adult patients who have PSC, I think that in general, the way I consider it and discuss is that the main outcomes that we care about and try our best to avoid seem to be determined by the PSC and the strictures themselves of the bile ducts. And we have tools, imperfect as they are, to reduce the inflammation from an autoimmune hepatitis standpoint in the majority of cases, but the strictures and how they behave over time, in my view, tend to be relatively similar from that aspect.
Dr. Assis, can you comment about some of the trade-offs and risks of having an ERCP, specifically the issue with scope contamination that's been in the news lately versus non-invasive measures such as an MRCP?
Yeah, great question. So there have been some case reports, cases of scope contamination. I know that led many centers to re-examine their policies and how this is cleaned. I think outside of some specific protocol issues, there has not been a widespread issue with contamination of ERCP scopes, and so I certainly wouldn't hear those reports and get the impression that an ERCP, specifically if it's necessary, of course, for dealing with the stricture, is a high risk for infection. I think those are very isolated, rare circumstances. The issue of whether to do an ERCP in the first place versus an MRI, as I said, there is this recent study from Germany which suggests that doing ERCPs frequently can be helpful, but that's a research study. I think that reality also, we have to really weigh the issue of complications. It just takes one episode of pancreatitis to understand that these are potentially not so benign procedures, and it's a real give and take, I think, with the patient and the provider and the person who's doing the ERCP if it's not the PSC provider, because there's different tolerance for risk. My personal opinion is that I still manage with MRCPs in the sense of monitoring for changes, and I'm not overly eager to put somebody on a regular ERCP schedule, but I think this is an area of discussion.
Okay, thank you. So Dr. Heimbach, I think this is getting at a marginal liver graft. So how do you, or could you please discuss, quote, Class B grade liver? What does that mean? Is a different allocation method used for those grade B livers?
I like that, grade B. So right now, no, the system is the same for all types of livers. With the new proposed system, the one that is currently not going forward because of the lawsuit, we do have a sort of a more local allocation for the livers that are a little bit harder to place. So donors over age 70, we use those livers all the time in Rochester. We think they're fantastic. Other people have more concern because of what I mentioned. You go out and you look and you have to go home without doing a transplant. So that's a lot of work, and maybe why some people don't want to pursue that. It used to be that those livers didn't work well for Hep C patients as well, and now that's not an issue with the new drugs. So the new system, there will be a priority for our patients within 150 miles of the donor hospitals, so they'll be allocated to that first, all the way down to, basically down to the whole list, so before it goes to the bigger circle. So more quick to place those, harder to place, which is again donors over 70, and donation after cardiac death. We spent a lot of time talking about those livers yesterday. I do think there's a lot of reason to be cautious in accepting a DCD liver, donation after cardiac death liver, for a patient with PSC, but an older donor liver probably is a good option, and so that's what I can say about that.
Thank you. For Aliya and David, fatigue is a common and difficult to address problem. Can you comment about your general approaches, and is modafinil helpful in your experience?
So the first part is our general approach. So fatigue and symptoms, like I showed in my presentation and in that chart about symptoms, definitely happen. And I think that we as providers need to be open and listen to our patients who tell us that they have these symptoms. So is it there? Absolutely. Are we good at managing it? No, because in my mind, there's no medical therapy that is helpful. I don't think modafinil works. I don't tend to use it in my practice very much, but I do think that there's more than just pharmacologic therapy in managing symptoms. I think using a non-pharmacologic approach is important. So I tend to tell patients that, listen, the first things are easy. Let's make sure there's no other cause of fatigue that we're not treating, be that hypothyroidism or sleep apnea or even just troubles with sleep hygiene. Trying to improve sleep hygiene is important. Keeping things dark, no noise, no anything that could be distracting before you're trying to get to bed is important to do. And then ruling out other causes of fatigue is my first line of defense. And then after that, I think you have to accept that some symptoms are difficult to treat and are part of the disease, and we do our best to try to give you strategies to improve quality of life and improve symptoms of fatigue, like focusing on sleep hygiene.
Yeah, I agree. I also don't use modafinil. One of our colleagues, actually Mayo trained as well, Marina Silvera at Yale, had done a study here about modafinil in PBC, primary biliary cholangitis, different disease, of course, but it was not effective for that condition. But one of our interests, at least at Yale, is on mindfulness as a stress reducer, but also as a potential intervention for fatigue. We have some pilot data in autoimmune liver disease that it certainly can reduce the level of some of the inflammatory cytokines, and we know that even beyond the biology and how the brain might be connecting to the liver, that there are very well-known effects of mindfulness, meditation, and other aspects that can increase energy, reduce stress, reduce fatigue. So I think that that is a non-pharmacologic area that needs to be further explored because I think there really are biochemical signals that are being sent throughout our whole body by doing that.
Great points. This will be the last question before we break for the lunch and other sessions. So this one is for Dr. Assis. So in asymptomatic patients, does a, quote, dominant stricture, end quote, seen on an MRCP have the same clinical implications as an ERCP-defined, quote, dominant stricture?
It's a good question. There is not, as of yet, I believe, a perfect correlation that has been studied. I think the MRI working group and others from the International Study Group can help us with this, which is, does the stricture as seen by an MRI have an exact correlation to the size and characteristics as a stricture seen by ERCP? I will say that a dominant stricture, if it is found, needs to be taken seriously because the practical point here is that occasionally you can have cholangiocarcinoma inside or associated with a dominant stricture. So I would take a dominant stricture that's suggested by an MRI seriously and move forward with evaluation.
Agree completely. I'd like to just give another round of applause to our speakers. Thank you very much.
Thank you, Drs. Eaton, Assis, Gulamhusein, and Heimbach. That was another wonderful session. You talked about so many practical concerns that we all have, and you actually gave us really good answers for some questions that were pretty tough, because I know we're always asking, what do we do about fatigue, this, that, and the other, and you actually came up with some ideas. So we appreciate that. So thank you very, very much. It was great. So we're going to eat again. One question, a reminder I have, we always try to get one photo of everybody together. And so as soon as I finish these few announcements, if everybody will just stand outside the auditorium and we'll just try to get a photo and squish together, okay? Also, our lunch boxes this time, because from here we're going to break into our peer support groups, the lunch boxes are going to be back this way, where you had registration on Thursday and Friday. Just follow us, we'll get you there. So what you're going to do, you will look at your tag, and on the back it will show you what your peer group is. That's right underneath your, if you don't know it by now, underneath your name. And then take the agenda, because that'll show you what room your peer group is in. Pay attention, because some of the groups are big, so you have to know if you're in your A, B, C, or D within that peer group, so you'll get into the right room. If you have any problems finding your place, we have our usual roving volunteers. Speakers, if you signed up for lunch, your lunch group is also listed on the back of your name tag. Enjoy your lunch. Please go to the blood draw, visit the shop, see our vendors, get the nutrition survey. Be back in your seats here by 1:45, and please come quickly for the photo. Thank you. Yes, Don?